Well, it's my great pleasure to be able to introduce Professor Murray Esler, who's going to give the Paton lecture. My name is Julian Paton, and I'm a research scientist at the University of Bristol. I'm in the Department of Physiology and Pharmacology, and my research interest actually overlaps with much of what Murray's going to talk about. But what's distinctive about what Murray's going to talk about is that he's working as a clinical physician and works with people, and what I do is mainly work with animals. But our interests have a big overlap, and that being in essential hypertension. If somebody says to you, Murray Esler, there are two things that come to my mind, and the first thing is the technique which he has pioneered, which is noradrenaline spillover, which is an indirect way of measuring sympathetic activity, which he's done in humans. And he's been a great advocate of the whole idea that one of the major drivers of cardiovascular disease is overactivity of the sympathetic nervous system, which has been hotly debated and contested. And to have Murray, who has shown absolutely vividly, as you'll see in his lecture, that the sympathetic activity is absolutely paramount for these diseases, fully backs up everything that many, many basic scientists have been doing in animal models of these diseases. The second thing that you think about when Murray Esler's name is now mentioned is this very recent and highly topical, exciting work that he's doing with renal denervation. And this may provide a non-druggable approach to treating hypertension.
It's a great pleasure to be here today talking to the Society. And giving this lecture in memory of Sir William Paton. Many of you, I'm sure, have personal memories of Sir William. He was a very, very distinguished pharmacologist, started his scientific career at the National Institute of Medical Research in Hampstead, and finished it as the long-serving chair of pharmacology at Oxford. Along the way, he made many discoveries, one of which, with Nora Zamus and Walter Perry, was the discovery of methonium drugs, and relevant to my talk today, the development of ganglion blockade as a treatment for hypertension. He was very, very active in civic duties. At one time chaired something like 100 national committees, and so soon after Royal Ascot, I should mention that he successfully chaired the committee for the abolition of doping in horse racing, which is of relevance to me as an owner, but not in UK. My story starts with the work of the School of Neuroanatomists in London, led by Thomas Willis, who give us the first identifiable picture of the sympathetic nervous system. In 1664 it was published in a monograph. One of that group was young Chris Wren, also an astronomer at that time. 2 years later, the Great Fire of London came, and the civic fathers found other duties for young Chris Wren, who became Sir Christopher, of course, and devoted his life to architecture. Fast forward 200 years, with not very much happening on the sympathetic nervous system in the interim, we come to the giants of physiology of the 1800s, who identified the sympathetic nerves as nerves that influence vascular calibre and blood pressure. But the transmitter remained unknown until Ulf von Euler, a Swedish physiologist, using techniques which don't really satisfy today's standards, very simple bioassays, but with a good idea behind them, identified the transmitter as noradrenaline. And the way he did this, he looked at different tissues and their responses. Some of the tissues rather unlikely ones, like pregnant rabbit uterus, looking at adrenaline, noradrenaline, and extracted transmitter from beef spleen, and correctly identified noradrenaline. And not long after, Sir William, with help from his colleagues, developed ganglion blockers, which were first introduced into clinical practice a little later in the mid-1950s, and saved a lot of lives, but of course caused a lot of misery in terms of multiple side effects. Now, a guiding aphorism for this talk is this one. I've stolen it, I must admit, because it was from Bismarck in a corrupted form. Bismarck said, "Diplomacy is the art of the possible." I think if we ask the French, they would say Bismarck decided diplomacy often was not possible. And in clinical research, there's a tightrope you walk. You try to devise incisive methods, but with clear ethical restraints. It might look like sometimes we blur this division a little in the sort of clinical model that I've applied for 30 years. And typically it involves studies in humans involving infusion of radiotracers to do isotope dilution measurements of, in particular, noradrenaline release, placement of central venous catheters, which sounds a bit much, but done by cardiologists is pretty easy, and nerve recording with microneurography. And this enables us to be a little more incisive with our methodology than is often the case. Now, the guiding scientific principle is sympathetic responses are often differentiated, regionalised, and you have to look where the action is, in the kidney, in the heart, rather than using global measures. And the techniques at our disposal currently are microneurography to measure nerve traffic and measures of noradrenaline spillover to plasma from individual organs. Microneurography, many of you will know, subcutaneous recordings in humans from nerves to skin or skeletal muscle vasculature, recording multi-unit firing or single fibre refiring. To look at the internal organs outside reach of electrodes in humans, we have to use neurochemical techniques, and a useful one is this, in which a tracer is infused, tritiated noradrenaline. Sampling is done from the veins draining, say, the heart or the kidney. Sorry about that. And measuring the washout of noradrenaline from these organs, the outward flux as a measure of sympathetic function. For example, in the heart, this involves putting in a sinus catheter, a thermodilution catheter in the coronary sinus, infusing tritiated noradrenaline and calculating the outward flux, which gives us access to the sympathetic nerves of the organs. Now, what I want to run you through is this emerged discipline of cardiovascular neuroscience, and in fact 4 examples with some history and the current state of play in heart failure, psychogenic heart disease, which is heart disease attributable to mental stress and psychiatric illness, disorders causing postural syncope, and essential hypertension. These might look very disparate, but in fact there are elements that bind these 4 together. Now, I'm going to describe the pathophysiology, but more important to me as a clinician is really the translation of this to clinical care, which is mature and well developed in a couple of those examples, but very much work in progress in the others. And I'll start with heart failure. And the story dates from work by Chuck Chidsey and his colleagues in USA 45 years ago, where they measured noradrenaline in the myocardium of the failing human heart. and they found the concentration of the transmitter was very much reduced. Noradrenaline concentration was perhaps 30 or 40%. And the conclusion was, well, the heart's denervated. There's a functional and probably an anatomical denervation. But there was a clever cardiologist in Colorado called Michael Bristow who measured adrenoreceptors in the failing heart and found that the abundance of beta-1 adrenoreceptors was very much reduced, perhaps 30% of normal, but this was selective. Beta-2 receptors were at a normal level. And he said, this can't be true. It has to be there's increased neural drive to the failing heart. An application of isotope dilution methodology showed that to be true. A study by my first PhD student, Greg Haskey, and noradrenaline spillover from the failing heart was very much increased in heart failure, as Bristow suggested it would be. A subsequent study with David Kay looked at whether this impacted on the longevity of heart failure patients. And in patients with severe heart failure on a transplant waiting list, outcome was very much dictated by the level of sympathetic tone in their heart, which was often extraordinarily high, with spillover values perhaps 50 times normal. And split on the median, those with the highest sympathetic drive to their heart did much worse. Armed with this sort of information, Bristow and colleagues then set up the first beta blocker trial, the carvedilol trial, which showed benefit of beta blockers in heart failure and confirmed with other agents. So heart failure, the pathophysiology is pretty well demonstrated now. Recordings by Clive May in heart failure sheep show clearly activation of nerve traffic, and translation to clinical care is mature. Let me now turn to the second aspect of cardiovascular neuroscience, and this is a very controversial area and disputed. And it's been disputed because for a long time all we had were anecdotes. Some of the anecdotes were very good ones. You'd know John Hunter's story. Had coronary artery disease and a very bad temper, and that comment is attributed to him, and after a stormy meeting of the hospital board, clutched his chest, walked into the corridor and died. So there were some powerful anecdotes, but it took more to convince skeptics, and this was important in convincing the skeptics that mental stress, acute mental stress, can be a trigger for heart attacks. This was the Northridge earthquake in Los Angeles quake of 1994, and on the day of the quake, sudden non-traumatic deaths were markedly increased. There were many more examples of this. By the time of the Twin Towers disaster, many Americans had implanted defibrillators in situ, which could be interrogated after this. And in the next 3 or 4 months, there was a flurry of firing in defibrillators. There was a classic study from Florida. The firing rate was threefold increased. So Americans were scared witless, and not just for a day or two, for months, and it translated into ventricular fibrillation. It's a bad time to show this slide, I'm sorry. But you'll get your revenge when you see what happens here. That's what they looked like as they were cheering the wrong side. But this is the good news for English people. So this is the World Cup of 2006 in a classic paper published in the New England Journal, and what it shows is heart attacks in German nationals living in Munich. The study was in Munich during the World Cup, and the background is what usually happens in Munich, and the numbers are what happened during the World Cup. And the first three is the qualifying round, and in the first two games, German people were on the edge of their seat, but a lot of them actually fell off the edge of their seat with cardiac events. They'd got through with game three. That there was less emotional heat in this by then, and the peak of adverse events was later. There was less. Game four, they won pretty easy. I can't remember which match that was, but it didn't impact on them too much. But the next one was the penalty shootout with Argentina, where they dropped like flies. And then the next was the game against Italy, which they lost. Number 7 reflects the playoff between semi-final losers for third and fourth. Well, who cares? And they were not terribly interested in the final either, between Italy and France. So I'm very sorry about what happened to your boys in South Africa, but they did you a favour. But the message is here, there's a dose-response curve, a plausible dose-response curve between acute mental stress and acute cardiac events. And obviously not studied in the field, but in the laboratory what can be shown, and we've shown this, is there's a very pronounced activation of the cardiac sympathetic nerves and a flood of adrenaline into the circulation. And what's going on in cardiological terms is that the pressure can cause rupture of plaques and thrombosis. There's a very pronounced hypokalemia during acute mental stress attributed to the adrenaline. There are sympathetically mediated arrhythmias in the presence of coronary stenosis. Activation of platelets contributed to thrombosis. And as I'll show you, you can, in some circumstances, get coronary artery spasm. Now, some people have their own emotional earthquakes out there in suburbia, people with panic disorder. And I've reassured panickers for many years that the last thing they need worry about is their heart, but in fact it's not true. Cardiac events are not uncommon during panic attacks. We've been able to measure sympathetic nerve firing during panic attacks in half a dozen patients, and what you find is a massive increase in burst size, perhaps not unexpected. Also, what we find and have documented in some people is this coronary artery spasm. In my clinical care of these patients, as I've said, I've seen patients with recurrent arrhythmias, people with infarcts. This is a 50-year-old female barrister who had panic attacks in court with angina. So we did an angiogram, and she had a panic attack during the angiogram, and she got coronary artery spasm, which was relieved by a nitrate. Not shown she actually developed ventricular fibrillation, which she was shocked out of, and has been well with medication for the next 10 years or so. So this is just a clinical example of the translation of acute mental stress events into cardiac risk. Some of you will have heard of this condition, another expression of adverse cardiac response to acute mental stress, called Takotsubo cardiomyopathy, stress cardiomyopathy. And this is a ventriculogram of the heart during diastole, well filled. And in a patient with stress cardiomyopathy, the apex of the heart has not contracted, so you get ballooning of the apex. And it was described first by Professor Sato in Japan, who likened it to the octopus pot, or Takotsubo, with a narrow neck and a dilated base, in this case, equivalent to the apex of the heart. Now, the context is this is usually very severe mental stress, such as news of sudden death in a family member. Although sometimes it's puzzling, the stress. I organised a conference a couple of years ago, and a speaker was Ilan Wittstein, who's has a lot of clinical experience, and he described something that surprised him. He said, I had a patient and the distress didn't seem proportionate. She was a very stylish woman who went on an upmarket camping holiday and bought new clothes, and she was in her tent dyeing her hair, and a windstorm came and she spilt it all over her new outfit and got Takotsubo cardiomyopathy. And all the men in the audience laughed, and my wife, who's a psychiatrist, whispered to me, that would give me Takotsubo cardiomyopathy. We had an epidemic in Melbourne. We had an epidemic. You remember we had terrible forest fires a year ago in Melbourne, where I work as a cardiologist. Every one of the major public hospitals had cases of Takotsubo cardiomyopathy triggered by this natural disaster. There's a lot of work to be done by experimental physiologists. As cardiologists, we haven't been able to work out the mechanism too clearly. It's commoner in women of middle age or elderly women. There are some surprises here. When you look, it's thought to be mediated by neural mechanisms in the heart, or perhaps adrenaline, but when you look at the distribution of nerves, which are dense at the base and not so dense at the apex, it's the opposite of what you see in terms of myocyte dysfunction. So there's a lot about this condition we don't understand, but it's a very explicit example of a stress cardiac adverse response. Just on this segment of the talk, I'll now finish off on depressive illness, where there's very clear evidence of depressive illness is a risk factor for heart attacks, right up there and equivalent to the risk with high cholesterol or hypertension. Cardiologists were never going to discover this. It was discovered by a social scientist, Nancy Fraser Smith, working in a department of cardiology. The mechanism isn't clear, but it has been known for some time that the sympathetic nervous system is activated in depressive illness. You'd think depressives would be flat and de-energized, and certainly their sympathetic nervous system would reflect that, but it doesn't. We've looked at whole body and cardiac sympathetic activation in people with depression. This is a psychiatrist who did a PhD with me, David Barton, and this is the distribution of noradrenaline release from the whole body or the heart, with a surprising bimodal distribution. About a third of patients have noradrenaline release in their heart as high as you see in heart failure, where it seems to be able to kill patients. The grey area is found in normals. We haven't been able to act therapeutically on that. I mean, the question is, does this very high level of cardiac sympathetic drive contribute to this cardiac risk of depression? No one's done a beta blocker trial in patients with depression. Some may need it because of the fact that many depressives have drug-resistant depression. So at this point, the integration of these sort of ideas into clinical care is very limited. So this is very much work in progress in terms of the transition of physiology to clinical care. We're working on it. I organised a conference in Prato 2 years ago. It's on again this year. Tuscany turned out to be a very stressful environment, not because I organised the conference. I had all my family there and I had to hire a 10-seater van. You can't imagine what it's like driving 10-seater vans around the hills of Tuscany. Don't try that. Now we'll move on to point number 3, and it's really a situation in which the sympathetic nervous system fails in terms of its job. I don't know if you have kids who are aged 3 or 4 or 5, some of you will, I'm sure. If you do, you'll know about the Wiggles. The Wiggles are a group of Australian entertainers who entertain little kids, and they wear monochromatic coloured shirts. And Yellow Wiggle, Greg Page, shown here, has severe orthostatic intolerance and had to retire from his work. And why he had to retire was he particularly hated it when he fainted on stage. Poor Yellow Wiggle is dead. You know, he couldn't continue with his work because of that. So now what I want to talk about is the pathophysiology of disorders of orthostatic intolerance and how we might treat it in the new era. And there are a few phenotypes. One is the neurodegenerative syndromes, like pure autonomic failure. There's this odd one, characterized by extreme heart rate response to standing, which I won't talk about anymore. And then there are patients who just for no apparent reason faint often, have falls, injuries, very poorly understood condition of recurrent vasovagal syncope. And from a clinical practice, I identified that quite a few of these have very low supine pressure, and they're usually just reassured by their family doctors, what are you complaining about? You'll live to be 100 with a blood pressure like that. But in fact, they have a lot of disability. So I'll describe the results in patients like this. Fainters who have either normal supine pressure or very low supine pressure, and it's often very low, 75 or 80. And we applied the typical sort of methodology, nerve recording and measures of noradrenaline spillover during head-up tilting, and with a twist thrown in, which I'll describe. Now, when we put these patients on a tilt table, which is the way the research is done, there was a surprise when we looked at nerve firing rates, and this is the group with low supine pressure and low pressures during tilting. And despite that, they had really increased, chronically increased, and on the day of the tilt, sympathetic outflow with very high rates of nerve firing. When we look, this is the normals who doubled their nerve firing, and this is the group of fainters who have normal supine blood pressure who look normal here. When we looked at noradrenaline spillover to plasma, what we find is the expected increase in health, but in the patient groups, much lower noradrenaline spillover than normal during tilt. Particularly surprising in this group, if you remember, they had really high sympathetic nerve firing. So there was an electrochemical disjunction in these patients between nerve firing and noradrenaline spillover. The low supine blood pressure group had very high nerve firing rates but low noradrenaline spillover, and the normal supine BP group were normal in terms of nerve firing but had virtually no increase. So we tried to take this further, looking at sympathetic nerve biology, which is a bit of a challenge, getting sympathetic nerves in sufficient number which meet ethical requirements. And it turned out that taking a biopsy from a small vein was a good source of sympathetic nerves. So a subcutaneous vein was the source of tissue, and we looked at tyrosine hydroxylase as the rate-limiting enzyme in synthesis, but a couple of other proteins that are relevant, the vesicular transporter, Dynamine-1 involved in vesicle recycling, and the noradrenaline transporter. And we did the biopsies, extracted the proteins, and did Westerns with appropriate antibodies. And this was an early slide. The low supine blood pressure group looked like they had somewhat lower TH, And that was confirmed in larger numbers, looking at the asterisks. In the low supine blood pressure group, very markedly reduced TH, shown in the histogram at about 10% of the level. So the inference here is there may be a problem with synthesis of noradrenaline, which causes this electrochemical disjunction. We haven't looked whether this is mutational. Tyrosine hydroxylase is a very large and difficult gene. We haven't looked for epigenetic mechanisms, but in terms of protein abundance, that's how it's heading. Now, in the group with normal blood pressure, it wasn't quite as clear-cut, but we found something strange, and that was there was increased abundance of the noradrenaline transporter. So this failure of noradrenaline to increase with tilting perhaps reflect greater recapture, so that that contributed to their predisposition to postural fainting and meant we didn't measure an increase in noradrenaline spillover. So that's, at the moment, just presumptive. So just to summarise, we're wondering if there's a sympathetic nerve protein signature, and as I indicated, the low supine BP group, perhaps driven by inability to synthesize noradrenaline, the normal group with a problem with noradrenaline transporter protein. We've described earlier that the POTS patients actually have low levels of transporter. So perhaps this might be an aid to diagnosis in the future. Perhaps it may be a basis for therapy. And how that could work is perhaps we could bypass a problem with TH by using this noradrenaline prodrug, dihydroxyphenylserine, which can be converted to noradrenaline by dopa decarboxylase and actually taken up into noradrenaline, used as a transporter. We've done work earlier in another deficiency disorder, dopamine beta hydroxylase deficiency, in which L-DOPS was effective. So we're in the middle of a pilot study administering L-DOPS to the low BP group, in fact are doing very well as far as the study has gone. Now I'll turn finally to the issue of whether essential hypertension is neurogenic, and that has a very long history, at least 100 years. And in the 1930s, 1940s, before we had drugs, there was surgery done, radical thoracolumbar sympathectomy done to treat uncontrollable hypertension. And it did save lives, but in effect it converted every patient into someone with pure autonomic failure. So they lived longer, but they had postural hypotension, neurogenic diarrhea, impotence in the men. So it was not a final solution by any means. And then we had ganglion blockers, which did it a little better than sympathectomy, but the side effect profile was not satisfactory. Now, even though I suggest hypertension might be neurogenic, that's very much a counterculture idea. The dominant drugs in hypertension care block the renin-angiotensin system, but there's a very strong experimental and clinical body of work over the last 20 years which suggests the importance of neural mechanisms. In experimental science, and Julian himself is on the honour roll, and in clinical science, where over 20 or 30 years there's very strong evidence, and Peter Sever, who may be known to some of you, did a lot of the early clinical work. But it hasn't caught on as an idea, and certainly not in therapy. In our own work, when we've looked at the renal sympathetic outflow, which we think is critical, we find that noradrenaline spillover in untreated people with essential hypertension without heart failure is often very, very high, except in the elderly. And in about 50% of patients under 60, it seems to be the driver. Why do I think the renal sympathetic nerves are important? Well, because of the experimental evidence summarised here by Jerry DeBona, that in many models of hypertension, renal denervation surgically ameliorates the hypertension, stops it developing altogether. So that's the background. You'd think that hypertension had a neural pathophysiology, but in fact the dominant paradigm is that it's driven by the renin-angiotensin system. This is an iconic picture showing the importance of the renin-angiotensin system at every stage, from risk factors through to death. But of course, when you look at drugs blocking the renin-angiotensin system, they don't do much better or any better than the other agents in terms of outcomes. So I think this is as much metaphysics as science, actually. And this led us to work to develop a new device that could tackle the sympathetic nervous system, and the ideology we've published in a Journal of Applied Physiology point-counterpoint article. And the idea was to do a selective renal denervation in hypertension. It was a study developed with my colleagues Henry Crum and Marcus Schleich in Australia, and a device company, bioengineering company, Ardian, in Palo Alto in California, and we had collaborators in Poland and Germany. And the catheter is a radio frequency ablation catheter, purpose-made, that is introduced into both renal arteries, much as you'd put in a cardiac catheter, with local anaesthetic into a femoral artery and then into both renal arteries, and it delivers energy. In the experimental studies, which we did in pigs, the aim was to produce about 12 degrees centigrade increase in the adventitia of the renal artery. And I mention that because in humans, the renal sympathetic nerves enter the kidney in the wall of the blood vessels, mainly in the adventitia. So the aim was to ablate these nerves without damaging the rest of the artery. The first study was done in patients with severe uncontrollable hypertension, just for the ethical reasons. People on 6 or 7 drugs with blood pressures of 180, 200. This is the first patient, my patient, Gail Lander, and we've looked to see, did we achieve denervation? And the only method we had really was to measure renal noradrenaline spillover at baseline and after the procedure. And there was about 80% reduction in denervation. This is a little unusual to have a patient's name on a slide. Gail is the first patient, and she said, look, I'm a pioneer. You're not using my data unless you put my name on it. So, Gail Lander. And this is the first trial results published in The Lancet a year ago. And the procedure, on top of the existing therapy, lowered blood pressure by that much, which is quite a lot. Many people had pressure controlled. Some were on less medication. Some now need no medication, but most need some. 2 years on, and we've got follow-ups to 2 years, the pressure is maintained. There's no evidence of a cancelling out of the effect by denervation. The drug now, the device has regulatory approval for clinical use in Europe, which sounds a bit premature on the basis of one trial, but so be it. Some people are trying to suggest this. Perhaps we might even have a cure for hypertension. If you did this in people with mild disease, there may be scope to get them off all medication. Of course, the procedure would have to be demonstrated to be perfectly safe to use it in mild hypertension, and you'd have to be sure that reinnovation was not going to be a big problem. But I try to avoid getting too far ahead of my data. I can remember catastrophes of the past by doing that. So at the moment, Julian can talk about cure of hypertension, thank you, but I'll just steer clear of that. So let me summarise. In this field of cardiovascular neuroscience, the relevance of the sympathetic nervous system to cardiovascular disease and to clinical care, heart failure provides a mature model of translation from pathophysiology to clinical care. With psychogenic heart disease and the disorders of postural syncope, this is very much work in progress, with transition to clinical practice to come. With hypertension, I think perhaps we're on the cusp of translation of the pathophysiological knowledge to clinical care. Thank you.